Good afternoon. My name is Emily Halowinski, and I'm here to provide you with an in-service on the high-risk stroke survivor and how we manage their care here at DRHA. The intention of my in-service is to educate you as an interprofessional group of learners on the high-risk stroke patient that you will at some point be tasked with caring for along the care continuum. To educate you on performing the appropriate recognition, assessment, and management of the high-risk stroke patient, and that you will gain foundational knowledge to prepare you to recognize the symptoms, address risk factors, and provide evidence-based holistic care for our stroke patients. In reality, you will need to use the information contained in this in-service and some hands-on application and practice to obtain the maximum benefits. But I will provide you with some starter tools, if you will. By the end of the presentation, attendees will be able to apply this knowledge to improve patient outcomes and satisfaction, reduce morbidity and mortality for these stroke survivors, improve care coordination, and reduce risk to provide health promotion. Let's first talk about the patient population. Stroke is often confused with being a neurological condition, but it's actually classified as a cardiovascular disease or event. Stroke is defined by Mass and Safdie as a sudden loss of neurologic function resulting from focal disturbance of cerebral blood flow due to ischemia or hemorrhage. Each year, there are about 130,000 deaths in the United States alone associated with stroke events, making it the 5th leading cause of death in the US, behind cardiovascular disease, cancer, respiratory infections, and accidents. Stroke also leaves behind quite a wake in its path, with nearly 700,000 stroke events in the US each year. Over 70% of them are first-time strokes, and nearly 30% are a recurrent event. Nearly half of those 700,000 stroke survivors each year are left with some level of disability or impairment. At this point, our best treatment remains prevention. The standards of care for this particular patient population are built around coordinated multidisciplinary services and care. Stroke patients have the best outcomes when they receive care in acute stroke certified hospitals, on acute stroke inpatient units, by acute stroke trained healthcare providers who also have the access to neural rehabilitation departments and specialized services that can identify, treat, and manage the complex needs of stroke patients, like identifying and managing risk factors like blood pressure, diabetes, blood lipids, and atrial fibrillation, to managing the functions, both pathophysiological, cognitive, and functional, and managing the complications that could be involved, including falls, DVT-PE, aspiration pneumonia due to a dysphagia, seizure due to the cerebral edema or a new hemorrhage, and skin breakdown and contractures due to prolonged periods of immobility. Early and appropriate education seem to have the greatest impact on designing a care plan for a stroke survivor. Adoption of healthy life habits remains the cornerstone to preventing reoccurrence of stroke and improving the functional outcomes of stroke survivors. Due to the effects that smoking and diabetes have on the cardiovascular system, the risk for stroke in diabetic persons and persons who smoke is almost double. Patients with diagnosed hyperlipidemia or hypertension can significantly reduce their risk with proper medical management paired with appropriate lifestyle and diet modifications. The majority of stroke survivors are discharged from the hospital on a statin and some type of blood pressure medication meant to be followed by their primary care physician. Research also shows that the right set of risk factors can dramatically reduce their risk and reoccurrence of ischemic stroke events with the addition of a daily aspirin at discharge. Patients with organized and consistent follow-up seem to have significantly reduced risks of reoccurrence, as well as much better functional outcomes due to better adherence with their medical management and following through with their rehabilitation needs. As mentioned earlier, stroke is the result of a vascular disease. The vasculature in the brain is an intricate, delicate pathway that essentially ensures that all the central control centers of the brain are being oxygenated with a healthy, consistent supply of oxygen-rich blood. A stroke event occurs when that blood flow is interrupted by either a thrombus or an embolism in the vessel, if it's an ischemic stroke, or a rupture of the vessel that causes bleeding into the surrounding tissues, which is a hemorrhagic stroke. A different set of circumstances leads to each type of stroke event. Ischemic strokes usually occur in the presence of atherosclerotic disease in the vessels, a hypercoagulable state for the patient, be it cancer or perhaps infectious in nature, in which case the patient would have an additional set of symptoms due to septic emboli occluding the cerebral vessels. Hemorrhagic strokes are often the result of arteriovenous malformations or tumors causing weaknesses in the vessel wall, making it susceptible to rupture. Coupled with unmanaged or poorly managed blood pressure, the need for perhaps an anticoagulation therapy due to atrial fibrillation or a prosthetic heart valve, and patients who abuse alcohol or recreational drugs also have a higher incidence of hemorrhagic stroke events. We also need to make mention of the TIAs, or quote-unquote mini strokes, in which the symptoms spontaneously resolve within 24 hours. These often go undiagnosed and untreated relative to risk for subsequent events, but following in a pattern of these transient attacks, often when a patient presents with their current symptoms, they were preceded by similar symptoms that had subsequently resolved. The neurons in our brain are obviously very sensitive to the cerebral blood flow, and they begin to die within minutes of complete cessation of oxygenated flow. As I said, the symptoms and presentation of a stroke depend on the type and location. However, the typical presentation of a stroke involves at least one of the American Stroke Association's 5 SUDDENs, be it sudden numbness of the face or a limb, especially if it's on one side of the body, sudden confusion or unintelligible speech, sudden change in vision, sudden trouble walking or maintaining balance, and sudden or severe headache with no known cause. The American Stroke adapted these symptoms into a FAST acronym when educating out in the community. The F for facial droop, the A for arm weakness, the S for speech difficulty, and T for time to call 911. Obviously, as care providers, we know that should we witness or encounter someone with these signs or symptoms, even if they resolve quickly, to activate the stroke code within the facility to make note of the time so that we can help pinpoint the last known well should the patient require intervention or thrombolytic agents. An important part of assessment and treatment for stroke patients is a consistent tool for assessment. The National Institute of Health Stroke Scale, or the NIHSS, is the gold standard relative to providing consistent and measurable progression of symptoms and the prognosis for recovery. It's super quick. It can be completed in about 10 minutes, and there's certification for all levels of care providers to ensure the consistency and training behind the true assessment. The NIHSS assesses 6 major areas, including loss of consciousness, visual assessment, motor and cerebellar function, sensation or neglect, and the cranial nerves. With possible scores all the way from 0 to 42, a clinician can help to classify the severity of the stroke event and better predict the prognosis for recovery. While in the acute phases of a stroke, as well as during the early recovery phases, there are certain physiological metrics that need to be closely monitored to prevent complications and perhaps subsequent events, including blood pressure, blood glucose, the patient's neurological stability, assessment of any heart arrhythmias, and regulatory functions such as temperature regulation and oxygenation. In the presence of an ischemic event, blood pressures will require tight parameters to ensure adequate perfusion without putting the patient at risk for a hemorrhagic conversion event, should include vessel rupture. Additionally, in the presence of a hemorrhagic event, too high of pressure can lead to a patient hemorrhaging again at the distal part of the affected vessel. Very important to monitor blood pressure. If you're going to diagnose a stroke, it's important that you try to obtain as much pertinent patient history as possible. The risk factors, the medications, preceding factors to the event, these can be valuable pieces to the patient management puzzle. Additionally, it's important to obtain blood work detailing electrolytes, glucose, the coagulation, and ruling out infectious etiology. It's valuable to rule out cardiac events or toxicological causes for the event. The gold standard for emergent diagnostic scans is a CT scan, which can delineate, it's an emergent non-contrast scan. So you don't have to worry about allergies, but the CT can delineate hemorrhage versus ischemia. Diagnosis can be taken further. MRI can determine the location and extent of the injury and also be the determining factor for a thrombolytic treatment. In the event that a subarachnoid hemorrhage is considered, a diagnostic lumbar puncture can determine the presence of increased intracranial pressures resulting from the bleed. And depending on the circumstances in which the patient presents, you can use additional diagnostics, including an echocardiogram for the cardiac etiology, thrombus, or perhaps vegetative masses, carotid duplex, for large artery atherosclerotic etiology, and the MRA or angiography from the large vessels could show occlusions, dissections, and aneurysms. The definition of holistic care includes addressing the physical, emotional, social, economical, and spiritual needs of the patient. In regards to stroke survivors, the biggest struggles pertain to the interplay between the patient's neurological impairment and their level of physical and functional assessment. Because acute stroke patients may not be aware of their new functional limitations as the result of this impairment, so early, frequent, and consistent education need to be adapted, followed by a patient teach-back or assessment that they have an understanding of their needs and their risks, which is super important. For best outcomes, stroke survivors need early rehabilitation initiated as soon as medically appropriate to prevent many complications of the acute stroke, DVT and PE, skin breakdown, contractures, constipation, pneumonia, and possibly most important, the patient's morale. These patients also need an individualized and coordinated care plan for the management and follow-up, including education about risk factors and symptoms, appropriate monitoring should they require anticoagulation, the appropriate rehab and resource referrals, and establishing consistent and timely follow-up care. Stroke is the leading cause of disability in the United States, with nearly 350,000 stroke survivors impacted by some form of disability. Nearly half of those left with disability will have cognitive deficits, while nearly a quarter of stroke survivors will still have a functional disability that impacts their ability to function independently with their activities of daily living 6 months after their stroke event. Additionally, 2/3 of stroke survivors will experience at least one of the previously identified complications during their recovery, and it doesn't necessarily have to be during the acute phase. Knowing that prevention is the best treatment for strokes, these potential outcomes and complications are best addressed by consistent and reinforced education surrounding diagnosis, their risk modification and management, the importance of medication adherence and timely and appropriate follow-up care, which can be augmented by well-coordinated and individualized care plans to address a patient's barriers and resource requirements for a safe and successful transition home and back to an optimal level of function. I have some references should you care to review, and I'd like to open it to question and answer quickly.